So generally, in routine clinical practice, no formal geriatric assessment is done prior to decision making because it is very time consuming and it caters to it is easy to practice without geriatric assessment. However, the geriatric patients are also not represented well in the clinical trials, and hence it is very difficult to extrapolate the results of clinical trials into routine practice for elderly patients. So before implementing a treatment plan for the elderly patients, other factors like life expectancy, functional status, mortality risk from comorbidities, and the risk of disease progression or recurrence are considered in clinical practice. However, managing older patients with breast cancer is complex. Hence, treating patients solely based on clinical judgment can either lead to under or over treatment. That is why geriatric assessment using validated geriatric tools or scales is very helpful to capture deficiencies or vulnerabilities in different health domains. And in this study, we have tried to utilize shorter geriatric assessment tools for patients who were registered at a hospital for seeking breast cancer treatment. This was a prospective study which was done to predict 1 year mortality in older breast cancer patients who were more than or equal to 65 years, and we had used different geriatric assessment tools. Generally, the gold standard, which is the comprehensive geriatric assessment tool, is a very time-consuming process, and it is not possible to implement it routinely in clinical practice. Hence, we use three shorter available tools for geriatric assessment, and those were multidimensional prognostic index, geriatric aid tool, and onco multidimensional prognostic index. We had done a single time assessment at the index visit when all the consecutive patients who were registered at a hospital for seeking breast cancer treatment were screened and accrued in the study. We captured all the demographic as well as the clinical data along with the treatment history to study the compliance rate to the treatment as well as correlate them with 1 year mortality.
So the median age of the study cohort was 70 years. 22% of the patients were metastatic and 98% of them were female. The treatment completion rate in the cohort was 75%. 1/4 of the patients did not start the treatment or left it incomplete. We found out that 1 year mortality at median follow-up of 19.3 months was 12%. Proportion of patients under the moderate and severe risk category under onco-MPI were 85% and under MPI were 7.7%. We did not see any survival difference between these groups compared to the mild category group for both of them. Coming to the geriatric age score, 15% of them had lower scores, and it was seen to be statistically significant. So when we did a multivariate analysis, we analyzed different prognostic factors, among which the cancer stage, treatment compliance, the molecular subtypes, and the geriatric age score predicted the 1 year mortality and were found to be significant. So we saw that neither MPI or onco-MPI helped us to predict the mortality in this exclusive cohort of breast cancer patients. The best tool was found out to be geriatric aid. Hence, I conclude that we should look for more cancer site-specific tools for geriatric assessment. So if we compare the study with the previous studies, like the original study by Brunello et al., as well as the study which has been done in the Indian group of patients by Shenoy et al., both have been published. So we saw that there was a difference between the study population in terms of gender, cancer stage, as well as the site of primary. So maybe that is why our results have not come significant as it was seen in these two studies.
So my final conclusion from this study was that we have used the same tools that have been reported in literature and they have been found to be predictive. But this was not the case when we analyzed the same tools in a homogeneous cancer site. That is, the study was done only in breast cancer patients, and we did not have any distribution of male versus females because 98% of our patients were ladies. And despite having more patients in the high risk group, as according to the MPI and Onco MPI, there was no correlation with survival. So this suggests that we need to have a more India-specific or cancer-specific tool that will be meaningful and which can be also reproduced in other cancer sites. So when we are running geriatric assessment, we have to also take the cancer site as one of the important factor, and also see whether what are the causes of death. So if the more patients that have been that are dying because of disease, uh, and that is not the case actually in breast cancer patients, because patients do survive for a longer time. Even metastatic patients do survive for a longer time. Hence, it is important to develop cancer site specific as well as tools that take into cognizance the socioeconomic and the demographic profile of the patients, and it can vary from country to country. Uh, this brings me to make another point that we are going to run a study which with a tool called Scope C, which has been developed by one of the expert geriatrician from AIMS Delhi, and this tool we would be validating against the comprehensive geriatric assessment, and we are about to start up with this study in near future. Thank you.